Hi, good evening, and welcome back to OrthoHub. I'm pleased to invite you all back in the new year. This is our first major outing for 2021. My name is Ramon Tamasebi. I'm an orthopaedic surgeon in London, and I'm one of the OrthoHub team. For those of us who are joining for the first time, welcome. And OrthoHub is a free interactive community where we endeavor to provide really high quality education for everybody across all the fields of musculoskeletal surgery and at all experiences as well. We have got loads of interesting back content, and you can view all of that on our YouTube channel. In terms of what we've got in store for 2021, we have been working really hard to bring you some constantly evolving and really original content for the new year. But immediately coming up in the next month or so, we have got a webinar which we are hosting on our platform in collaboration with the International Orthopaedic Diversity Alliance. We are definitely committed to diversity and inclusivity on OrthoHub, and we're really proud and honored to be hosting an intercontinental webinar on our platform, and that's going to be in February. Alongside that as well, we're going to continue with our, standard orthopedic content before unveiling some interesting new stuff later in the year. And we envisage that the next thing that we're going to deliver from our point of view is going to be something on hips. So stay tuned. And if you subscribe to our YouTube channel or our website or our various social media forums, we'll be able to keep you updated with new content as it comes. Recently, we released one of our probably best ever podcasts with Mohit Bhandari, where Cash and Pete talk through everything all the way from rap music to research with Mo Bhandari, who many of you will recognize as a global leader in orthopedic surgery and probably one of the most influential and respected orthopedic surgeons in the world right now. And it's a fun, informative, really easy to listen to. And if you haven't listened to that, I strongly suggest that you do. Please help us by supporting and following us on the various platforms that I mentioned. And in particular, if you stay subscribed to the YouTube site, you'll get access to all of the case takeaways and all of the back content as well. So I will briefly introduce our host for this evening, and that's Kate. Kate is an old friend of mine who trained in London, but then went on to become a highly regarded hand and upper limb and peripheral nerve surgeon in Derby at the Pulvertaft Hand Centre. She also works at the Regional Major Trauma Centre at Queen's in Nottingham, where she maintains an interest in those subspecialties and peripheral nerve surgery. And last but not least, it's worth mentioning that she is a lieutenant colonel in the army and must be obeyed at all times. We are also very proud and privileged to welcome our international speaker, and that's Chris D, but I'll let Kate introduce him formally. But I will mention that Chris has a fantastic podcast himself called The Upper Hand. And if you're interested in hand and upper limb surgery, that's definitely worth tuning into. I've had listened to a few of them and they're fantastic. So enough from me. I'm going to hand you over to Kate.
So thank you very much, Ramon, and good evening all. Well, it doesn't need me to say you're in for a really, really interesting evening today. We have got some of our top experts in the field of both peripheral nerves and brachial plexus, and they're going to be sharing their experience and their thoughts and their views on nerve stuff, and it is going to be quite a treat of an evening. Just before we move on, as is always the case, we've got some housekeeping points. You are going to be seeing some really interesting cases today, but we do ask you to respect our patient privacy. As far as is possible, these images have been anonymized, but please, they're not for being shared to the public platforms. We're going to be doing a few questions and answers at the end of each talk, and then there will be time for much more talk at the end of all of the 3 talks. But if you can put your questions down in the Q&A, you're all now probably very well versed with how to do this, and I'll try and do my very best to get to as many as I can, but obviously can't promise that they're going to all get answered. And the other interesting thing you're going to have is a bit of a geek out at the end of each talk, so 90 seconds for each of the speakers to be able to give you something really super specialist. So without further ado, we're going to go on to introducing our first speaker for this evening, and that is Mr. Tom Quick. So Tom, following on from his fellowship at the Royal National Orthopaedic Hospital, the PNI unit, he was appointed there as a consultant in March 2013. Can't quite believe it was that long ago now, Tom. His main interests are in obstetric brachial plexus palsy. He also deals obviously with all the traumatic nerve injuries, and that obviously very much includes all of the brachial plexus work. But he also has a significant interest in the peripheral nerve treatment of spasticity, as well as nerve injury and the development of the growing shoulder. He's probably got one of the largest obstetric palsy practices in the UK, and he has worked both at Great Ormond Street as well as the Evelina Children's Hospital. He's got an incredible amount of experience in supra and infraclavicular plexus injuries. I'd also like to mention he does like to put his theory into praxis, testing the effect of cold water on his peripheral sensory nerves whilst he's doing his open water swimming. So without further ado, I'm going to hand you over to Tom.
Well, thank you for that intro, Kate. It's a pleasure. As I go through the takeaway that I've done, I have feedback at the end with me with severe hypothermia, gibbering like an idiot. So if you do want some entertainment, I'll cover it again at the end of this talk, because I'm not entirely sure I covered any of the points I intended to, due to the coldness of my brain. My name's Tom Quick. As Kate very kindly introduced, I do just nerve at the Royal National Orthopaedic Hospital, and research interest UCL. Website at nerveinjury.co.uk, and please follow me on Twitter. There'll be some content following from here as well, I'm sure. If it's not just us singing sea shanties, you may have seen that. It's going to be a whistle top store, so you're holding on to your hats as we go. It's going to be fast and hopefully interesting and informative. And I will have 90 seconds to tell you a little bit about something that gets me inappropriately overexcited. My practice, as I said, is paediatric adult nerve injury all over the body. And I have a research interest as well with UCL, and we form the Centre of Nerve Injury, Nerve Engineering there. And that website's very useful for you as well for research things. So we're going to talk, what is a nerve injury? This is what most of you think about nerves. This is my bowl of udon noodle. And yes, the plexus does look a bit like that, but nerve is a highly functional concentrated structure. It's made up of nerve cells. We call the nerve the same as the nerve cells, but it's not just nerve cells in there. There's blood cells, blood vessels, connective tissue, and supportive cells, the Schwann cell, which is the supportive cell of the axon within the nerve. And nerves control everything that you do, every touch, feeling, movement, all communicated from your CNS to your PNS, central nervous system, to your peripheral nervous system. This is a neuron, the cell body there on the left. I think you can see my arrow. And then the axon, this is the working unit here that transmits with the action potential and in a myelinated nerve, saltatory conduction along backwards and forwards. And they control all of your functions, all of your bodily functions come through nerves. And the central nervous system in the middle there, encased in a bony box, never to be touched. And we deal with things outside of the dura. So all those other little bits of udon. And because they can affect any part of the body, it can have an effect in your arms, your legs, your chest, your abdomen, pelvis. And it creates a lack of muscle function. And I'll talk about that in my geek out. And numbness, dry skin, pain, stiff joints. So it's motor, touch, sympathetics, and pain. And that's all that the nerves do. And to remember all those functions of nerves, because quite a lot of you commonly would just say, well, there's a wrist drop, but not tell me that much about exactly what's going on with anything else. So we need to recognize that that's motor, touch, sympathetics, and pain. I'll give you a little way to remember that in 3-4 slides time. So they're delicate. They don't like being stretched. They don't like being squashed or cut. And these mechanisms are exactly the mechanisms that you see in trauma, like the twist of an ankle fracture, or the bend of a femoral fracture, or the impaction of an acetabular or pelvic fracture. It's exactly the same. Many of you will know about Seddon and Sunderland's classifications. Now, that's really important for you to know for the exam, but practically you need to go through every axon and classify them for that to make much sense. So a more general classification is to think about something as either a neuropraxia, more easily said is conduction block, and that says what it is, and we'll talk about that in just a minute, or a degenerative injury. A degenerative injury, imagine you're out in the garden, you cut a worm in two. You do not get two worms. That's not how baby worms are formed. You get one half a worm and a dead half a worm. And the same thing happens with an axon. So the cell body, the bit that can create the protein, the head in our little worm here stays alive, and the bit connected to that lives because it still has protein synthesis in the cell body. The distal bit dies away. A guy called Waller told us about that, so we call it Wallerian degeneration. So that axon dies away and the worm tries to regrow a tail. The same thing happens with your nerves. Here it is with the axon, it's cut, the distal bit degenerates, the muscle, for example, becomes denervated, and the bottom left in C, we see the worm starting to regrow its tail, and finally it becomes a fully functioning worm again. Here's a nerve laceration. All the little bits that look like sperm are actually nerves, axons with growth cones on, and you can see that quite a few have managed this. This is a proximal bit here, and they're growing across. You can see some have made their ways down into the distal segment. All these Schwann cells and basement membrane here to support them. All these ones have got a bit lost, and these have got really confused. And that's the growth cone, actin and myosin, just like a little amoeba smelling out where it wants to go. So that's degenerative nerve injury. Now that can be favorable or non-favorable. If those nerves, if that little green amoeba can find somewhere to grow, it will do. So in a crush injury here at the bottom, both of these injuries created at the same time, you can see all those axons have grown through. They've all got a basement membrane and Schwann cells, and they just grow through. But if you cut the nerve, the axons have got nowhere to go. Those little growth cones just get lost. They form a neuroma. So that's a degenerative injury on both of these. All the axons died and regrew. But on the top, it's an unfavorable prognosis. A neuroma is formed. Leave that for 6 weeks, 12 weeks. It's not going to get better. The crush injury will. And the way we can tell the difference is these growth cones, when you tap on them, have a Tinel sign. So Jules Tinel described after trauma, and that's important, after trauma, there is a tingling sign when you tap along the nerve felt in the distal territory of that nerve. And if that Tinel sign, the point where there's growth cones, you can find them by tapping, if that moves along, advances at a millimeter a day, an inch a month, then that's going to get better all by itself. There's a favorable prognosis. You have to do nothing, just predict the future and see it come true. But if the axons stay still, we need to go in and give that nerve somewhere to grow to. The opposite of this injury is called a neuropraxia. Neur meaning nerve, apraxia meaning not working, apraxic, not working. It's easier to call it conduction block. This nerve is anatomically intact, but physiologically broken. So it's there, but it's not working. It hasn't died away, so there's no Tinel sign. It's just like a fuse of a bomb. Imagine the bomb's the muscle, the fuse is the nerve. If the fuse gets wet, it's anatomically intact, it's still there, but it's physiologically broken. It won't transmit that conduction to make the bomb go off, the muscle contract. One other thing to recognize is around the environment of the nerve is also as important as what's going on with the nerve itself. And this is a cicatrix. This is what happens to trees when they get damaged. The same thing happens to nerve. You get contractile scar. And contractile scar compresses nerve, can create pain, can create persistent conduction block. And that, again, is a very important appreciation. It's not just what's in the nerve, it's what's around the nerve. So we go back, all these functions of nerve, motor, touch, sympathetics, and pain, might try something professional, MTSP. So remember, every time you see a nerve, you need to think about the mechanism. Has it been stretched, cut, bruised, lacerated? In the same way as trauma, you know, was that a train traveling at 100 miles an hour, or were they just hit with a tennis ball? Those differences in mechanism are really key in trauma, in nerves, just as it is in bones. But then we assess all functions of nerve, because that tells us about exactly what's going on. There may be a motor drop with those big, heavy fibers being damaged, but if you can say there's sympathetics there and some light touch, then you know the nerve's in continuity, at least to some extent. Muscle function, we're going to come back to this later as I geek out, but how do we assess muscle function? I'll come back to this later. Sensation, We need to recognize when we're assessing nerves that it's quite complicated, the branching of that nerve. You all, I'm sure, know your brachial plexus anatomy, and it mixes up root levels. And the areas that get numb relate not just to the root levels. If the injury is not here in the neck, if the injury is further down, there'll be different patterns. And understanding this pattern of nerve injury as opposed to this pattern of root injury is very important in assessment. So please don't tell me there's a C6 injury if it's an infraclavicular injury. So there's a C6 dermatomal pattern if it's an infraclavicular injury, because it won't be. It will be an affectation of the lateral cutaneous nerve or the superficial radial nerve or the fibers, C6 fibers to the median. So think about that. Sympathetic, sweating, hair loss, rugosity of skin. I'm sure you all know this trick. But if you have a laceration of a digital nerve, if you put a wet dressing around a finger, really useful in kids, and come back, you'll see that the side that has a digital nerve gets crinkly when it gets wet. That sort of pruning of the skin that you see when you've been in the bath for too long. And if there's no nerve there, there won't be that same sign. Pain, neuropathic pain is really important. You all recognize those descriptors: lancinating, shooting, burning, squeezing. It is very difficult to treat, but there are a number of surgical diagnoses that are surgically amenable. So please, please don't go, and I think talks later we're going to talk on this, but please, please don't just go straight to the diagnosis of exclusion, which is CRPS. If there are diagnoses that you can make, it is not CRPS. Neurosternalgia, symptomatic post-traumatic neuroma, causalgia, post-traumatic neuritis, all improvable, maybe not curable, but improvable with surgery. Nerve injury is complicated, is best treated in appreciation of the whole condition in an MDT setting. And because of that, this really is not something where you just do surgery, repair a nerve, and never see a patient again. It's as important what you do after your surgery, well, assessment and surgery, as it is what you do. It's decisions and then follow up rather than incisions. So just to remind you, mechanism, how is it injured? MTSP, looking at motor, touch, sympathetics and pain, looking for a TNL. Neurophysiology and imaging, they're useful, but probably not like you would expect. They're not going to give you an answer if you haven't done all of that first. My final point, the importance of a diagnosis. Nerve injury is not a diagnosis. Nobody would think sore knee is a diagnosis. Nerve injury is the same. It's an area of the body or a mechanistic system with dysfunction. We need to go beyond nerve injury to get a diagnosis. Is it a degenerative nerve injury? Is it a favorable prognosis, a non-favorable prognosis? Is it a majority conduction block? These are important things to know about the mechanism of the injury and the likely nature of the nerve injury, but also the anatomic location. So what areas of the nervous system are involved? So people will often say, never at all. I've never heard any orthopod say this is just an injured shoulder. It'll be a labeled, a slap lesion or whatever else. So no one ever says this is a classic case of injured shoulder. It will almost certainly get better all by itself. But how many times have you heard this is a classic case of nerve injury? Almost certainly get better all by itself. If you've examined all those functions of nerve and you understand the mechanism and you know the diagnosis, then you can talk about natural history. But unless you've got a diagnosis, you cannot give a natural history, and you can't therefore say if intervention is going to improve upon that, or indeed what the condition or prognosis is likely to be. I'm very briefly going to touch on my quick case, the orthohub case that I put up. As I said, I was a gibbering, chattering idiot on my video, so just to make it clear, supracondylar fracture that presents like this in the morning meeting. Obviously, this is a far from ideal situation, but in the morning, it's been made a mess of. And the reason I picked this case is because we don't have the problem of thinking that we don't want to take it to theatre. Everybody wants to take this back to theatre. But what do you do if you have neurologic or neurovascular involvement as well at the same time? And I think that's for general discussion. I have very strong feelings on this because I recognize the anteromedial entrapment. So the artery and the median nerve, the brachial artery and the median nerve run across that anteromedial aspect of the antecubital fossa. And our guidelines are very clear. If you've not read the Boast and the Blue Book, please do that. Excellent guidelines for your care. But with this kind of stretching and the periosteal tearing and that sharp piece of bone, it's very easy that this can all get entrapped. entrapped within the fracture. And you often see, so here on the right hand side, here's proximal, here's distal, here's our fracture line, and just a nerve that's just tethered, just held in tight. And it's relatively straightforward. It can often look like it's periosteum. So doing an S-shaped incision across the front of the elbow, knowing the anatomy, be aware that that artery and that nerve are just going to be pulled tight. They're going to look like periosteum. But if they are involved and the fracture is malreduced, there is probably a reason for that. It's been difficult, probably because all this is caught in the fracture site. So there's that bony spike. And if you take it out, here's that bony spike. You can just see that's been dragged in by that periosteum and that fascia. And this in time will improve. There's no neuroma here. There's a bit of a post stenotic swelling, but this nerve did just fine. Sometimes, and that was the end of the case after we'd released that and everything had improved. Sometimes it's actually in the bone. So this was a bit later, another case entirely, but the nerve goes into the bone, it's all healed up, comes out again here. The only thing we're then able to do, if you leave this till 10, 12 weeks afterwards, is excise the bit that's in the bone and put some nerve grafts in. So that's a very much more significantly challenging case. Often with these as well, we can flex up the elbow and undertake a primary repair, but in this child that really gave me no space in which to do that suture. So we put some grafts in and that all went rather well. Mechanism, might try something professional. Tunnel, and really please remember that diagnosis.
Brilliant. Thank you very much, Tom. That was excellent. You've actually already come to a couple of the questions that have already been asked. But one question that has come up, which I think is quite interesting, and it would be also good to know from the rest of the panel. So the role of imaging in nerve injuries. So a good example being a brachial plexus traction injury, and someone's arranged for an MRI of the plexus and it's come back as normal, but clearly you've got signs that there is a plexal injury. So the question being, what is the role for imaging in these kind of injuries? So I might actually ask Chris as a starter. What's your feeling on this, Chris?
I agree with Tom entirely. Imaging will not supplant the examination. The vast majority of what we, how we decide things as peripheral nerve surgeons is based on the physical examination, perhaps electrodiagnostics. Imaging, I don't think has quite caught up yet. That being said, I mean, I had a case exactly like perhaps the one that was described, in which there was a sharp, what ended up being a sharp laceration of the upper trunk, and the MRI of the brachial plexus that the patient came in with was originally interpreted as normal. That being said, an MRI is only as good as the person interpreting it. And I did collaborate with one of our neuroradiology colleagues who I work with all the time and asked him to look at it. And he said, no, this is clearly a laceration of the upper trunk. And lo and behold, it was a lacerated upper trunk. So, you know, you can't rely entirely on imaging. It is one piece of the puzzle. It helps if it triangulates well with the rest of the data that you've gathered, fantastic. But don't hang your hat on it. I don't know if that's a saying in the UK, hang your hat on something, but you know, we say that here in America.
It's a great saying, Chris. I'll go with that. So then actually the next thing I was going to ask is there ever a role in getting an MRI scan? Is there ever something that anybody feels is useful? CY, do you ever get imaging?
Oh yeah, well, I work very closely with my radiologist. The way I use imaging is to support my diagnosis or to refute my diagnosis. So before I order the test, I've more or less made up my mind about what I'm going to do with that injury. So I use imaging sometimes to support my diagnosis or to look for evidence to prove me otherwise. However, I think we'll keep on coming back to this, where clinical assessment is always the key. Having said that, I'm aware of some very exciting development in MR neurography, such as imaging the roots. So there will be really advanced detail, but that is still not in mainstream use. It's still in developmental, experimental stage.
Yeah, I do think, you know, particularly with the plexal injuries, you know, certainly getting an MRI of the C-spine to see whether or not you've got any evidence of a root avulsion, there is a role for that. But no, that's very interesting. One other quick question I've got, back to you, Tom. So you talked about MTSP. Sensation in particular, we all I'm going to say, go back to what Chris said, hang our hat on the whole 2-point discrimination. But actually, my question to you is that actually a useful thing? Because I actually think probably the return of protective sensation is what's really important. And so I'm just interested to know what your thoughts are on that.
Yeah, so Josh Harold, who's an academic occupational therapist, has essentially thrown out the fact that 2-point discrimination is much use, moving 2 points much better, but still, to me, it's presence or absence of sensation, but more than that, it's the quality. So it's a subjective experience. So describe that to me. Is it 10 out of 10? Is it 5 out of 10? Does it feel fluffy? Is it strange? Is it tingly? Is it painful? And light touch pain, so the misinterpretation of light touch sensation as pain, which is allodynia, is a sign that there is still an ongoing nerve injury. Very commonly, nerves that are still squashed, compressed, stretched, create this allodynia. And so it's a really important sign to say, A, the nerve is in continuity, because you're touching the skin and the brain is getting that message, but that misinterpretation is a really important sign. So light touch pain, or even deep touch pain, muscular pain on palpation, really important to you. The nerve's in continuity, but that quality is really important.
Right. I think we'll move on at this point. So now it gives me great pleasure to.
Do you not want me to geek out? We're going to do that.
Didn't we just? You want to do another geek out?
No, I'm happy. I thought I was going to. That's fine. That's fine.
Oh, no. Well, if we do that now, we can. Yeah, we can do that now.
Let's do it in 60 seconds rather than 90.
Do that now.
Okay, perfect. So, are you timing me? Am I timing myself?
I'll time you.
I'm going to start. I've got 60 seconds. I'm going. So I want to talk to you about muscle assessments, because this is what I did my thesis on. It's what excites me. If I ask you as an orthopod to examine a muscle, you're going to tell me peak force. You're going to tell me how strong that muscle is. Now that is great, but it's not everything. So the MRC grading is pretty much utterly pointless. It is not linked with patient satisfaction. In my thesis, I looked at a group of patients who had muscle reinnervation for elbow flexion via nerve transfer, and we looked at their force. It was normally distributed, which was wonderful, but what we then found out was that wasn't linked with patient satisfaction. What is the subjective lived experience of reinnervated motor function? Is it painful? Is it owned? Is it graduated? Can it sustain contraction? Does it work with the other muscles, or does it co-contract? So patients tell us that that is important. That is linked with outcome. Peak force is not. And I have 4 seconds left and I'm done.
You should go on just a minute. That was good.
That was repetition, I'm sure.
No, that was good. There was no repetition. Well done. No, listen, thank you very much for that. And just like to tell everyone that Tom will be doing a podcast with Pete and Cash in the not too distant future. So definitely looking forward to that. Thanks very much. Which now leads me on to, as I said, the great pleasure I have of introducing our international speaker. So thank you very much for joining us. This is Chris D. Hope I've pronounced that correctly, who is a board certified orthopedic hand surgeon who has got obviously a subspecialty expertise in brachial plexus and peripheral nerve injuries. So he has done a postdoctoral fellowship at the Hospital for Special Surgery in New York City, and then he did his hand fellowship at Washington University Orthopedics. He's also an assistant professor of orthopedic surgery at the Washington University, and has got several quite interestingly diverse research interests, which include the quality of the delivery of patient care. And I think that's a great sort of addition to what he already does. He's been to various places of expertise to improve on his training, including India, China, Taiwan, Thailand, and Sweden. And he also likes to test his cyclist handlebar palsy whilst he's smashing out a really good session on his turbo in a 1 Peloton workout. So we'll be looking forward to hearing about that later. So without further ado, if I can hand you over to Chris.
Kate, thank you for that wonderful introduction. I appreciate it. And thank you to Tom, CY, Ramon, and the rest of the OrthoHub team for having me. Let me go ahead and get my screen going here. And I'm going to move this over here. So for my talk today, can everybody see the slides? I'm assuming you can. If Kate, if you want to just show me your video and give me a thumbs up that you can see everything. Good. So again, it's a real honor to be here today and to join the group here, a fantastic group of panelists. Clearly a day of import over in the colonies. We are very, most of us are very pleased to see a change in things, although there are many that are not pleased. But it's an important day for us. And also it's hard to have some fun in the setting of the COVID pandemic that's affecting everybody across the world. But we will try to have some fun today, talk about one of our favorite things, nerves. And, I tweeted this when, the tweet about the panel came on, and it really is an honor. It's, Cash went so far as to say it was like Elvis teaming up with the Beatles. I like to think of my co-panelists as S Club 7 and myself as more Bruno Mars. I thought that was a better fit. But thank you for having me. In preparation for this webinar, I spent a lot of time doing some British immersion. I went back and watched some of the original episodes of The Office. I also pulled up some episodes of The Crown. Basically, I think it's like Hamilton. Tom is the king, King George, and I am young Alexander Hamilton here trying to prove my worth. And also, as Kate mentioned, I prepared by, doing some training with the current British royal couple du jour, Ben Aldis and Leanne Hainsby. So shout out to One Peloton UK for all of that nice work. A little bit about me, like Kate mentioned, I'm currently in St. Louis, which is in the middle of the country in Missouri at Washington University. I grew up and went to college and medical school down in Miami, did my orthopedic training at Hospital for Special Surgery, and then came to Washington University in St. Louis. St. Louis is known for this symbol, the Gateway Arch, which marked the westward expansion of the United States. It was at one point the 4th largest city in the US and was a city that was well known. This was the host of the 1904 World's Fair and actually hosted the Olympics in the same year. And that was pretty much the apex of St. Louis's fame in the United States. But we continue to be a city of quite busy medical training and a lot of great nerve for us to share with you. I do have some conflicts of interest to discuss. I do have some research funding from the US NIH as well as the American Foundation for Surgery of the Hand. I have done a couple of ad hoc consulting things with Axogen, and we will talk about process nerve allograft. Those consulting fees were directly transferred to the AFSH, and I did not see any of them personally. So the big take-home points for this talk are that watch and wait is indeed an active process. It's not something that you can rest on your laurels. You want to do something professional, like Mr. Quick told us. One of the mantras I was taught is never fear the nerve you see, and also to get out of the zone of injury. And then technical excellence is of super importance when dealing with peripheral nerve, as Tom mentioned. So one of the scenarios here is that I think the nerve is cut or badly injured. What do I do now? I would say at the very beginning, don't bury your head in the sand. As orthopedic surgeons, we have a tendency to think that everything is going to get better with regards to nerves. Like Tom mentioned, we take a different approach to nerve as we seem to take to more musculoskeletal injuries. Not all of these injuries are neuropraxic injuries. They will not always get better on their own, and you do need to keep a keen eye on the examination and actively watch and wait. So here is a bit of a decision-making algorithm. Is the nerve intact? Sometimes our partners have explored the wound, or we have explored the wound ourselves, and we can say, no, the nerve is not in continuity. And you are looking at a surgical reconstruction, whether that is direct coaptation repair or a grafting in that zone of injury, or perhaps a distal nerve transfer when conditions are favorable, obviously considering the health of the patient overall. The mechanism of injury to the nerve, was it a sharp, tidy type of injury, or was it a blunt mechanism or a stretch, or even a firearm injury? And whether somebody else is going to be going back and doing additional surgeries and looking at the local soft tissue environment. If the nerve, if you're not entirely sure about what's going on, say, for instance, you think the nerve is intact, that is, I think, a role for imaging. And we talked a little bit about that in the preamble to this. And one of the chat participants did mention ultrasound. I like ultrasound for perhaps, confirming that the nerve is in continuity and you're not dealing with a neurotometic injury. If you think you are dealing with either a neuropraxia or an axotometic injury, watchful waiting, and this is an active process. And for both of these, an EMG nerve conduction study can be helpful at the right time. Now, these won't be useful right away, but after Wallerian degeneration has occurred, as Tom mentioned, at that probably 6-week mark is the most useful to start seeing if there's any recovery, although the most important one probably is about the 3-month mark. So I don't really need the 6-week study if I can't get it. And then all of this is trying to determine a prognosis. You're taking all of your information, your clinical examination, your nerve studies, perhaps your imaging, to determine whether this is a nerve that is indeed going to get better on its own, or whether this is a nerve that you are going to need to intervene on. So in my practice, just as an overall summary, patients that are going to surgery are those with inadequate recovery of axonometic injuries, and I have followed them over time to see that. And then all neurotometic injuries. So here's an example of a case, a patient with a humeral shaft fracture as well as an olecranon fracture that was fixed by one of my trauma colleagues. He was kind enough during surgery to take this picture and send it to me. During his anterolateral approach to the humerus, he identified that the radial nerve was not in continuity. So this was great from my perspective because it actually helps speed up my decision-making process. I know that the nerve is not intact and I don't need to sit and wait or get any other imaging to determine that. And, as many of you are familiar with, time is function, and the rule of 18 months that you need to get regeneration back to that neuromuscular, distal neuromuscular unit before the irreversible atrophy of that muscle occurs. So never fear the nerve you see. If you are in that area and you have the skill and the ability to expose the nerve and give us that information, I personally feel that that is very helpful. There's a lot of controversy out there, and some of it is surgeon preference as to whether the presence of a nerve injury, preoperative nerve palsy, is an indication for surgery in and of itself to gain this information. I'll leave that for the discussion. Then also what to do when you see, two ends of a nerve in a wound. And I think the right thing to do is to call your colleague who would be ultimately treating these injuries, somebody like Kate or CY or Tom or myself, and say, how would you like me to handle this? Would you like me to put a very loose suture in here and tack it to the fascia? Do you want me just to leave it alone? Do you want me just to take a picture? These are all things that you should discuss with the consultant that you'll be working with. So here's the remainder of this case. It was a proximal end of the radial nerve. You can see over here on the left side of the screen, the distal end. We're in a lateral position here. And you can see the posterior cutaneous nerve of the forearm that Gerwin originally described to help with the approach to the nerve. And it leads us right to the area where the nerve is injured, or is in discontinuity. And here's what we see after we cut back the healthy fascicles. We ended up doing a nerve graft in this setting as we were able to intervene in a timely fashion. So what about when the nerve is intact, but you're not sure how much of it is actually structurally in good shape and is working? So this is a case of obviously a median nerve injury. You can see the thumb over here, distal aspect of the median nerve within the carpal tunnel. Here's the wrist crease about here, and you've got this huge bulbous neuroma in continuity. And this is, unfortunately, in 2021, still a very rudimentary assessment. It's visual, it's tactile, and it's perhaps electrical, depending on the ability of your center. But then you ultimately end up cutting it open. And, one of the challenging things is that you do have to cut into the nerve to know the zone of injury in these cases, which can be a little bit terrifying as a peripheral nerve surgeon, but you need to be able to handle whatever comes across your table there. So if you are able to do a nice internal neurolysis, this is a technique that was described by the group from Louisiana State University and from Mayo Clinic. You could do a nice internal neurolysis, isolate your neuroma in continuity, and clean off your intact fascicles, and perhaps use intraoperative nerve stimulation to help you determine what is healthy and what is not healthy. That's one way of doing it. And when you can do that, that's fantastic. This is a case that was sent to me by my then senior partner, who is now retired, and one of my mentors, Richard Gelberman. And he was in the theater with me, and I said, hey, let's do an internal neurolysis. I think we can get some fascicles here. And he said, Chris, for every fascicle you can dissect out of here without cable grafting, I will give you a dime. And I said, great. But that analogy doesn't really hold weight in the UK. So it's about 20 pence. Again, forgive me if that's an incorrect conversion. But I thought, all right, let's try to do some neurolysis. Let's see what we can get. And I think I'm doing a pretty good job here. Here's the healthy nerve over here. You can see a nice little blood vessel. It looks like I see something in here that looks like it's in continuity amidst all this scar. So I'm here and I'm convincing myself and I'm asking the fellow, what do you think? And they're saying, oh, Dr. Gelderman's probably right. And I think, oh no, this is good. I can totally keep these fascicles, but lo and behold, these fascicles I thought were healthy here do not meet the distal end of the nerve. So he was right. He did not pay me anything that day. And then you have to cut into the nerve. And cutting into the nerve, I like using this Neurotome type device, although honestly using a tongue depressor, any sort of firm surface, and using a clean cut with a 10 or a 15 blade is also incredibly useful depending on where you are in the body. But you have to get out of the zone of injury. So you can see here, as we get towards healthier nerve, this is not completely perfect yet, but it's looking pretty good. You've got bleeding vessel within the nerve itself. You've got extruding fascicles out here. We'll talk more about that in a second. And progressively, you can see you've got just nasty, firm fibrotic nerve here. And as you get more distal, it starts to look better and better. So you want to resect back to healthy extruding fascicles. This is from Dr. Gelderman's book, actually. And these fascicles extrude because the nerve is an extension of the blood-brain barrier. And once you have that tension back in the normal tissue, you will see those fascicles extrude at this blood-nerve barrier now. And these bands of Fontana that you can see here, and also in this image down here, are reflective of the fact that you're in normal tissue. So to take that to a clinical photograph here, you can see the perineural edge right here. You can see this kind of nice epineurial, fatty mesoneurial kind of tissue too. And then your bands of Fontana back here. So this is healthy nerve, and you feel good about this because you don't want to be working within a zone of injury on the nerve because whatever you do, it's going to scar back down and you're not going to get any regeneration if you're not getting healthy fascicles across to healthy fascicles on the other side. So here is something that is unfortunately a relatively common injury where I live, a gunshot wound to the antecubital fossa. And I was told by the vascular surgery service that 85% injury to the median nerve. And, at that point I said, all right, well, we've obviously got to do something because I don't think this nerve is going to get better if we leave it alone. So we expose in the antecubital fossa, find the median nerve, and there's a scarred segment. I found a fascicle going to the flexor pronator mass over here, and I found the anterior interosseous nerve, which fortunately was still healthy enough to respond to some kind of stimulation, which says there's something coming across this nerve. And back to our scarred segment of the nerve over here. So I said, all right, let's see what we can do in terms of dissecting things out. And lo and behold, there were a few healthy fascicles that we were able to preserve over here within this loop here and within this loop here. But you've got unhealthy nerve here, or excuse me, you have to cut out these disrupted portions of the nerve here to here and here to here. And you can see the gap is still very reasonable in terms of something that can regenerate across a cable graft. So for that one fascicle up there, we did a single strand fascicular graft. And then for the remaining portions, we did a cable graft to bridge that gap. So the ulnar nerve has its own considerations. This is where you could potentially consider a topographical, fascicular type repair or reconstruction. Mobilization of the ulnar nerve and transposition can help, when you're taking care of these cases. Then one consideration is to use your anatomy, find your distal motor branch going underneath the hypothenar fascia, around the hook of the hamate, release that, and then you can neurolyse that back. And of course, this is beyond this talk, but we could have a talk about distal nerve transfer, supercharging, all that kind of stuff. I think the most important thing, if you're a trainee, is to realize that technical excellence is very important throughout all of what we do in orthopedics, but particularly in hand and peripheral nerve surgery. And as one of our the people we lost in 2020 would say, hard work outweighs talent every time. So studying, preparation, and practice, and if you don't have those things, you're leaving the outcome to fate. And one of my partners like to say that hope is not a surgical strategy. So this is where you really have to bring your A game in terms of preparation for the case and technical ability, and then know who to have on your team, somebody like Tom, CY, or Kate, if this is not something that you feel up for doing. If you are the one doing the nerve repair, or you are somebody who is sending us patients, this is what we think about. So we don't want to have tension on our repairs, because what happens with tension on your repairs is you will predispose to scarring. So there is kind of a sweet spot in terms of how much strain that nerve coaptation can handle. Less than 5% strain is the normal blood flow within a nerve. Once you get around 8%, you start to get temporary ischemia. And once you get in the neighborhood of 12 to 15% strain, you get irreversible ischemia and conduction block. And that is exactly what we do not want. Some people say maybe a little tension's okay. Maybe if you can bring it together with an 8/0 nylon suture, a 7/0 nylon, it's absolutely fine. But we know that based on work that was done in the lab, and this was actually done here in St. Louis, as you increase the amount of tension across a repair, you can see this drop off in terms of the axon counts after the repair. You can in the fiber density after the repair. So there is a threshold, and this is such an important decision that you really want to make sure that you're on the right side of that threshold. You can mobilize the nerve ends and do a neurolysis and maybe an ulnar nerve transposition to get a little bit of extra length, but you don't want to cheat too much. Again, some people still like to bend the elbow, bend the knee, for example, for a sciatic nerve or a peroneal nerve. That will get you, that will get the nerve ends closer together, but you do have to eventually move that joint. And some people, this is controversial right now, but some people will bend the knee, bend the elbow, et cetera, and then use ultrasound monitoring to look at their coaptations over time to make sure they don't disrupt. But that is leaving some things to chance and leaving some things up to the patient. And most of the times we want to have things in our control as surgeons. So grafting may be unnecessary if you're below that tension threshold, but it is high risk, high reward. If you go straight for a primary repair off the bat and you have too much tension, that ruptured repair could be catastrophic. Now, the downside of grafting is that perhaps you're going to have axonal loss at each additional coaptation. Depending on who you talk to, some people say that's between 30 to 50% of axon loss at each coaptation. So it'd be great to avoid that extra coaptation. This was actually studied in the lab of one of our colleagues, Amy Moore, and she looked at each additional suture line. And you can see here, you added the suture line here as opposed to having one longer graft here. And she did not see any significant decrease or even any real difference in the axons that made it across the coaptations. So that's one thing to consider. Ideally, you do avoid that second coaptation, but it is not something that should stop you from putting a graft in if it's the right thing to do in terms of avoiding tension. So everybody asks, what kind of suture do you like to use? Ideally you want a suture that fails, by 5% strain on average and a maximum of 8%, because if the suture is stronger than that and it withstands more strain, you're getting into that irreversible ischemia threshold of 12 to 15%. And you do want a suture that is going to break rather than pull out of the epineurium. So for a peripheral nerve, you want a suture that is strong enough, but not too strong, because you don't want it bearing the load of the entire repair. And the dogma, like I mentioned earlier, a lot of people say if it comes together with an 8/0 nylon, it's probably going to be okay. And 8/0 nylon does pretty well. Jeff Greenberg, the next president of the American Society, studied this in the lab, and 8/0 nylon does okay. But it tends to pull out, much more often than it breaks. And you actually want a suture that breaks. And then if you look at the strain, your 8/0 nylon is going to be, I guess it's right over here. Your 8/0 nylon is going to tolerate much more strain than your 9/0 nylon, which is intuitive. And perhaps a 9/0 nylon is better suited. And that's why I use a 9/0 nylon, because it meets all of your ideal characteristics. The argument about whether nerve glue, such as a Tecile or a fibrin glue, is an augment or an alternative. I will say in the United States, for the Food and Drug Administration, use of Tecile is off-label for nerve repair. I'm not sure of the exact regulatory environment over in the UK. But what this Tecile does is that it acts as an adhesive cylinder. It maintains its structural integrity for about 3 weeks. Some people think it's a little shorter than that. You can get some regeneration across the fibrin glue. And there are some centers in which you would use Tecile or a fibrin glue in lieu of suture. So a sutureless type of coaptation using this glue. It does not prevent fascicular extrusion. It is not a hollow tube, and that's very different. If you compare suture versus glue alone, there are equivalent results in animal studies. When it's added to a suture repair, you do get some increased resistance to gapping, but you do not have a change in the load to failure. So perhaps it's adding something to the structural integrity of your suture repair, but you do not want to count on it. In my practice, I use 9/0 nylon for suture repair, largely based on that Greenberg study, and I augment it with fibrin glue. I put enough sutures in so that it's well aligned and I don't have any extruding fascicles. You want everything tucked in nice and tidy. You don't want it coming out like this. And then I augment with the glue. I will protect the coaptation typically for about 3 weeks until I know that that blood nerve barrier has been restored. And again, a lot of that is dogma. Sometimes I will move them earlier. The situations in which I like earlier motion are for things like replantations or concomitant flexor tendon repairs in particular. So what if you can't repair that nerve primarily? There are a lot of different solutions out there in the literature. I think some of the test questions will still have you use a hollow tube conduit as opposed to a graft. I do personally have some concern for the inflammatory response that some of the currently available products will generate. And then if there is a gap for a sensory nerve that is over 2 centimeters, I like using a graft. Whether that is an autograft or an allograft is something that is up for debate. And personally, for me, I do not feel like allografts have a big role for any mixed or motor nerve deficits with a gap. I know that these allografts are not available everywhere in terms of where everybody is tuning in from. And then if you have excessive distance to target, nerve transfer can be really helpful. And that's something that we can touch upon shortly. So those are the numbers for me in terms of my current practice. This slide is mainly for cash. I wanted to include a Drake reference, but it's the guidelines, I believe, on your side of the pond are that the evidence for an allograft is sufficient for digital nerves, and I don't think anything else. So for those of you that are practicing in the UK. So nerve conduits, like I mentioned, these are hollow tubes of varying materials. They can, essentially act as a scaffold with that fibrin clot in between the two nerve ends. We don't really know what the critical length is. Less than 2 centimeters, you have pretty good results. And then as you get over 2 centimeters, the results are less consistent. These have been supplanted largely by a nerve allograft in my personal practice. When you're grafting a nerve, you want to make sure that you're getting a reasonable match on the diameter. You optimize your fascicular density, and it is helpful to reverse the polarity of your nerves. There are a number of studies, both in labs and humans, that have objected to the fact that you need to reverse the polarity of the graft, but it doesn't cost you anything. It just takes a little bit of extra time, so no reason not to do it. Your nerve graft is going to get its nutrition via imbibition, so you need a healthy tissue bed around there to supply that graft. And you want to make sure your cable graft diameter is not excessively large, because the central part of that graft will necrose if you make it too big. For example, if you're grafting a sciatic nerve. A couple of technical things about how I like to do my personal cable grafts. I do like to use these Neurotome nerve cutting sets, mainly as sizers, to be honest with you. You can see here, this is oftentimes, I will make a larger incision here. I know you can make smaller transverse incisions here. I know you can use a nerve stripper type device. Oftentimes in my practice, it is a trainee who's doing it, and I want them to be able to see that nerve, get it out safely. So this is representative of what one trainee did when working with me. You size up that graft. I like to glue the ends just to provide a nice little handling surface, retrim it after that. And then you get your nice graft. And this makes the handling of the whole thing a lot easier. Technically, just it moves together as opposed to having individual fascicles that you have to coapt separately. And this is a tidy looking graft after we've laid it in. In terms of your donor nerves, you have the Searles, obviously an option. This one tends to be pretty well tolerated. It's got the largest diameter. It's got a great number of fascicles. You obviously can use MABC, LABC, AIN, and PIN. These tend to shrivel up after you take them out of the body, which can sometimes make it a little bit frustrating. And these come with their own donor site morbidity issues. So in terms of nerve transfers, a whole separate talk, but what you're trying to do is take that same principle of a tendon transfer, and instead of transferring the tendon, you're transferring the nerve that's powering that muscle. And it does help you jumpstart recovery. You do have to think about, just like with tendon transfers, whether your donor is truly expendable. And this is one example we can use. This is a 22-year-old woman who had her left arm caught in a machine. I diagnosed her with a high median nerve injury. She had thenar atrophy present, and her extrinsic median function was starting to recur, but I did not think that this nerve would regenerate from her antecubital fossa all the way down to her thenar eminence in time. So I used I exposed the recurrent motor branch here, traced the recurrent motor branch retrograde off of the median nerve, and then found the hypothenar motor branch from the ulnar nerve, which you can see here. and transfer this nerve over, originally prescribed by Jaime Bertelli in Florianopolis. This has been a great addition to my playbook in terms of what we can do for these patients with high median nerve injuries, but that's a great illustration of that concept. And you can see here that she actually has done quite well. I had the 3-month video, now I have a 9-month video with her and moving her thumb over. Pretty good opposition for somebody who probably would not have had the ability to do that otherwise, and her extrinsic median nerve function recovered nicely. I will skip this topic because I know that CY is going to cover it in great detail, but the overall concept of decompressing nerves at known points of constriction, particularly if they have been injured more proximally, is one to keep in mind. So let's go back here. And to summarize, watch and wait is an active process. Everything that Mr. Quick described for us, that you need to actively do a professional physical examination, is incredibly important. Never fear the nerve you see. I think there's a reason why some of us go into hand surgery and nerve surgery, is that we're a bit fearless. We like to see the structures that everybody else is worried about, and perhaps that's our own issue. But if you have the ability to look at a nerve, either to protect it or to diagnose an injury, I personally think that is very helpful. You want to get out of the zone of injury to the nerve itself if you are the one doing the grafting or the repair. And obviously technical excellence is of great importance during these procedures. I want to thank Ramon for plugging the podcast, and Kate too. Check us out. It's been a lot of fun. I do this with Chuck Goldfarb, my senior partner at Washington University. You can see us interviewing Marty Boyer, the past president of the American Society for Surgery of the Hand, for the podcast. And if you're interested in nerves, we've just released a 3-part series on nerve injuries. And the last episode, we had a guest, Amy Moore, who many of you are familiar with in terms of her nerve transfer work. So thank you for the time. I appreciate the audience, and I'm happy to answer any questions as they come up.
Brilliant. Thank you very much, Chris. Are you doing a geek out at the end of this?
Am I doing what?
A geek out, or we just?
I can if you want. I have it ready. It's incredibly professional.
Let's roll with it. Yeah, we'll do the geek out straight away.
Yeah. All right. So I guess I should start my timer here. Hold on a second. What are you doing? 1 minute? 1 minute.
Yeah, 6 says just a minute.
Okay. So for cubital tunnel syndrome, a lot of them will get better without surgery. So don't do too much cubital tunnel surgery. Don't do an in situ ulnar nerve decompression if you have signs of advanced changes. So if you have changes in your 2-point discrimination, moving or static, or if you have signs of muscle atrophy, a decompression will not do much for that patient. Do a transposition instead. Or if you have signs of EMG changes or loss of motor amplitudes on your motor studies. Now, the reason not to do a decompression all the time is that there are poorer outcomes if you have to do a revision surgery. The revision rate is published as 7%. It's published from the same center as high as 19%. So if 1 in 5 of your ulnar nerve decompressions is getting a revision, that is not good, because they will not do as well as if you had just done an original transposition. If you are going to do ulnar nerve surgery of any kind, do it once and do it right. Only do a decompression if you can deal with the complications and know how to do it. In terms of transpositions, know how to do multiple types of transpositions, because the nerve may want to lay in different areas. And then if you are doing an ulnar nerve transposition, do not beat up your nerve. Treat it well.
Perfect. Thank you very much.
You're welcome.
I mean, that is actually, I think the role of decompression in the cubital tunnel, I think, is a very, very hot topic. And I think we do see a lot of cubital tunnel surgery being done, particularly without any form of magnification. I think if you're doing any kind of nerve surgery, there's one bugbear I've got: you have to have some form of magnification. So don't do it if you can't. Great. So lots of stuff coming out of that, Chris. Tom was doing a great job of answering the questions on the Q&A. So there's a couple of things that I think have come out of your talk, which I think would be great to pursue a bit further. And I think one of them is timings. So we've got a lot of questions coming about timings. When do we explore? When do we do nerve conduction studies? When do we do our neurophys and all that? So CY, do you want to come back to us? What are your sort of timing thresholds?
I think if you have time tonight, please do read the classic paper by Herbert Seddon, BMJ, the first paper on the classification of nerve injury, only 3-4 pages. But if you're a connoisseur, read the subsequent paper, which is like a treatise on nerve injuries. But in the first paper, you see Sutton set out the principle already. First thing, clinical assessment, history, clinical assessment, the energy of transfer. That gives you a very good indication. And then followed by serial examination. If the nerve is not progressing as you would expect, or if the nerve is deteriorating as you observe, you need to intervene. And then lastly, actually Sutton set it down, number 3 of the principle, of the key principle, exploration is part of the examination. If in doubt, then you explore. So I do not necessarily subscribe to a fixed time. Rather, one has to assess every case on his own merit. Anything to add, Tom or Chris?
Wrightington man, bigging up a Stanmore man. I cannot believe it. Sir Herbert Sutton. No, you're absolutely right. Absolutely right. I totally agree. Chris, thank you. Great talk. Really good. Enjoyed that.
Yeah, I think, but again, that highlights, doesn't it? The whole point of this is a dynamic process. This is not a static thing. You don't go in there and look at it once. This has got to be something that there is a continuity. You can't just leave them to fester without taking ownership of these patients. Another thing that you talked about, Chris, which I thought was great, was about technical excellence. And so I've just recently read Chris Hadfield's autobiography, which was a great book, by the way. And he talks about prepare for failure. So he talks about the time when they train for absolutely everything. So when people say to him, are you stressed? He's like, no, I'm not stressed because I can deal with anything that's going to come at me. And then he talks about the time when they had to go on this spacewalk and it all happened at a, they didn't have much time to do it, but they were ready to do it because of all the training they'd done beforehand. So what I'd like to know from all 3 of you is, how do you prepare for that technical excellence? What are the things that you do? So Chris, I think I'll start with you.
Well, I think you have to be prepared for every scenario. So on some of these complex panplexus injuries, we have literally written out, I think about these cases in my mind and I orchestrate all the different scenarios and I write out plan A through F that could possibly happen depending on whether we have 0 routes available, 1 route available, 2 routes available, it depends on what you're going to see. So you have to be mentally prepared for that. And I think to that point, you have to be able to do all of the things that are in your decision-making algorithm, because if you don't know how to explore the brachial plexus, you will not explore the brachial plexus unless you go out and get somebody to do that. And I think what CY was saying about, the exploration being an extension of the examination, that's critical. But if you don't know how to explore that nerve, you're not going to do it. So in terms of what you're asking, in terms of like actual preparation, I spent a lot of time in the anatomy lab, more as a trainee, but now whenever I can get in there, I get in there because sharpening your skills is going to be really, really important. And I think knowing your way around the body and the different regions that you're going to be operating in is incredibly important because, you can read as much Netter or whatever, websites you can or watch videos, but that's all 2-dimensional. And especially the plexus, that is a 3-dimensional structure with lots of depth. And the thing that many of our trainees comment on after we've explored the plexus is that now they say now it makes more sense. I didn't realize how much these structures were laying on top of each other. We think of the plexus as running like this, but it really is intertwined on itself like this. And I think that the more times you are in the lab, the more times you have the ability to prepare, the better.
Right. What about you, Tom?
Yeah, I echo everything Chris says, really. I think it's just doing it. You will learn from talking about it, and I think it's lovely to be up to date, to do the research alongside, do the teaching alongside. If you can teach something, you can understand it. You've got to have a real simplistic understanding. If you have that, you can teach it. It means you understand it. So I think that just living it, doing every bit of it that you can, and getting enthusiastic, having those geek out moments in your own practice, going, "This is so cool." It keeps it alive and keeps it working.
And what about you, CY? Final top tip.
I think I'll just echo whatever they've said. And I think a lot of us definitely do that mental exercise. We think about a case over and over. I'm sure we all do the same.
Great. Very applicable to surgery as a whole. So CY, on to you.
Thank you.
So CY he did his upper limb fellowship at the Wrightington Hospital, and he also did his national interface orthoplastic hand fellowship in Manchester. And he is now a consultant at the Wrightington, Wigan and Lane NHS Trust. So he's been to many, many places to explore further, the excellence of hand and nerve surgery, including Europe, North America, and Asia. He's also been supported by numerous awards that he's got along the way, including the BSSH Stack Fellowship and the Zimmer Scott Travelling Fellowship, as well as the BOA Travelling Fellowship. So he was up against it when he was first appointed, because he had to establish a whole new clinical practice for the treatment of peripheral nerve injuries at the Wrightington, but he's done an amazing job of that. And he has developed now a particular interest, certainly in the management of scapular winging, painful neuromata, and scaphoid non-union. So he keeps his hand practice in there too. And he also made good use of his anterior interosseous nerve in days gone by when he was strumming his guitar. I'm sure he'd like to tell you about that in great detail. So without further ado, I will leave you with CY.
Thanks, Kate, for the nice introduction, and thanks, Ramon, for involving in this project. So without further ado, with all the knowledge that you have gained from listening to Tom and Chris, Doc, release me. The disclaimer that I have is this presentation contains clinical and operative recordings. I would like to acknowledge my patient's permission and also their contribution to medical education. I have one key message for all of you, which is following fracture, dislocation, or surgery, please do consider secondary scarring or entrapment of nerve as a potential cause of pain and functional impairment. I'm going to show you a series of orthopedic cases that you should all feel very familiar at home with, and followed by 7 top tips of learning points. So case 1, let's start with someone who unfortunately had this injury during the first lockdown, which felt actually quite distant ago, but we are still very much in our lockdown. I'm not going to discuss whether one should fix that or not, whether pre or post COVID time or during COVID time, but in any case, she was treated conservatively. So 6 months later, she was referred with malunion, subluxed shoulder, and axillary palsy. The other thing is that she has severe pain with any movement. So you would immediately think of there's probably mechanical pain, but more importantly, there is neuropathic pain involved. So what did I do? I explored the quadrilateral space, and you can see here, this is the spike that you can see when I inverted the X-ray. The nerve were in fact stuck into this spike or bone. So this is after I have extricated the axillary nerve, and which you can see here. Prior to the surgery, there was no discernible contraction of the deltoid at all. But immediately after neurolysis, one can see evidence of contraction. So how do you reconcile that? Nerve injury is not always pure. More often than not, it's a mixture. There's clearly a mixture of neuropraxic component mixed with axonomatic, but the nerve has not been cut. And the first thing that this patient reported was pain relief. The requirement for painkiller reduced significantly. She still has a problem. The deltoid hasn't fully recovered, but it is recovering, but she's now in a much better position where she can consider future shoulder reconstruction. So tip number 1, successful neurolysis can provide significant pain relief and facilitate neural recovery. Next one, slightly more complicated, because the patient had an initial injury, recovered following surgery, but had a periprosthetic fracture, which was treated conservatively, healed. But she was referred at 8 months time point with an axillary nerve palsy. Now, this patient has severe restriction of shoulder and also pain. So in order to address all the problems, I performed combined approach to the shoulder. From the front, I had to perform a formal open contracture release. There was dense scar just within every tissue layer. The axillary nerve from the front, however, was intact. Then I explored the nerve at the back, and the nerve was not responsive. Because of the time that has passed, I elected to perform a nerve transfer, and subsequently she recovered very well with nearly full range of movement. So tip number 2, be an ultra holistic orthopedic surgeon. Many of you would know the definition of a holistic orthopedic surgeon, where you do not only consider the fracture, you consider the joint above and below. So why not consider the bone, joint, capsule, muscle, and nerve as well? Now let's move on to the radial nerve. This patient had a humeral fracture, which was treated non-operatively initially. At 6 months, she clearly did not unite. So she was offered open reduction internal fixation via an extended deltopectoral approach. However, post-operatively, she developed a very dense radial nerve palsy. So often we come across this saying, well, I never saw the nerve. The truth is, you do not need to see a nerve in order to injure one. Just imagine, for 6 months, the nerve was lying somewhere around this region. Meanwhile, the body was trying to heal. There will be inflammatory mass, there will be callus. And then you go in, you do something from the front, and you reduce this anatomically. What might have happened to the radial nerve? So this is the case where I explored the nerve from the front, but also the back. And the nerve was in fact encased in whatever callus that was forming there. So I have to extricate the radial nerve from the callus. And by 4 months, she started recovering the wrist. But you can see that there's still she's relying on tenodesis, but subsequently she recovered fully. So lesson number 3, when performing a delay fixation, be aware of distorted nerve and callus formation. Anatomical reduction could lead to unintended tethering of the nerve unless adequate mobilization has been performed. So I have not forgotten my lower limb colleagues out there. This is a case, young guy, road traffic accident, polytrauma, multiple limb injury, but all the nerves appear to be working as far as he could remember. So he had a femoral nail, but open reduction had to be performed, and post-operatively lost all the movement. It was not just a foot drop, but there was no movement and there was no sensation. Most importantly, she had a positive Tinel site. He also had significant neuropathic pain such that he could not sleep. So in this case, the timing, whether one should wait for another 6 weeks, 3 months, is irrelevant. There are so many warning signs telling you, save me, save me. So I did. So this is the posterior approach to the thigh. And you can see the spot of scar on top of the nerve. And this was after neurolysis. And a year later, he had a very good recovery. So tip number 4, Tinel sign, pain, and remember what Tom has talked about, the autonomic dysfunction. These are all signs of a nerve under distress. Listen to them. We are not talking about revision hip replacement, all the hip surgeons out there. So calm down. This is a case with leg length discrepancy, but also with foot drop. So my point being, think both orthopedically, think about the biomechanical issue, but also do not forget the nerve issue. Seddon, Tom, I'm going to come back again. Seddon, many of you are not aware that he was in fact an orthopedic surgeon. He was also a formidable spinal surgeon, in addition to being an amazing nerve surgeon. So anyway, come back to this case. I performed neurolysis combined with my hip colleague who performed a hip revision surgery at the same setting. I also routinely decompress potential distal entrapment point, in this case, the common peroneal nerve at the knee. Now, first thing this patient reported was pain relief. And also she felt the leg length was equal. She was delighted. Eventually, the foot drop recovered. So lesson number 5, when faced with nerve palsy following arthroplasty, please consider both biomechanical and neural issues. Now, in a nerve talk, we cannot finish a nerve talk without talking about CRPS. This is the Budapest criteria. We are all familiar with the pain symptoms, the sensory symptoms, the vasomotor, pseudomotor. It is very obvious when it is obvious, when you have all the signs and also bony changes, osteopenia on x-rays. But many people do not pay attention to this criteria number 4, where there's no other diagnosis explaining the symptoms and signs. The diagnosis itself is not an issue. The issue that I noticed is once somebody has been labeled or given a suggestion of CRPS, the response of orthopedic surgeon is that, oh, I can't do anything more, pain clinic. Now, why not work collaborative with the pain specialist, but do not forget about the patient, because you have to consider whether you have really excluded all potential causes of pain. Last but not least, the specific are not so important, but for the knee surgeon out there, this is a patient who had undergone many revision surgery. And this, like I say, the specific joint is not so important. But here, She was going around multiple complex knee clinic, and she had extensive investigation, X-ray, CT, MRI scan, joint aspiration, as you would when you investigate a painful joint replacement. But if you listen very carefully, her symptoms all fit into the dermatome of the peroneal nerve. She underwent nerve conduction, EMG, complicated but underlying medical problems, as well as potential spinal concern. She had gait analysis, but clinically, it was very obvious that she had localizing signs to the common peroneal nerve as well as the superficial peroneal nerve. In such cases, I have began using hydrodissection as an adjunct as part of my information gathering. And what you're seeing here is using volume injection around the common peroneal nerve. And after this procedure, the patient reported virtual instant complete relief of symptoms, but this was not long lasting. So she came back a couple of weeks later with recurrence of pain. And then I proceeded to perform a thorough decompression of the common peroneal nerve and superficial peroneal nerve. And you can see the nerve here really doesn't look very healthy. Tom referred to udon noodle. Actually, I have another analogy here. This is like a tagliatelle, which has been overcooked. Perhaps among the panel, we need to come up with a noodle pasta classification of how bad a compressed nerve looks like. That's an idea, isn't it? So last but not least, do not let a squashed nerve spoil your good surgery. In summary, clinical assessment is key. Pay attention to pain, sensory disturbance, weakness may or may not be present, positive Tinel sign, and autonomic dysfunctions. These together will give you a good indication whether there is a nerve in danger. But of course, put on your orthopedic hat, exclude important mimics, do the scans as you would. Do not be put off just because there is a nerve injury. You stop thinking, you forget that you still have your orthopedic hat on. There might be elements of the patient's complaint that you can deal with. Neurophysiology provides supplementary information, but it's not absolute. And ultrasound-guided hydrodissection, again, is not absolute, but it's a potential adjunct. Now, in carefully selected patient, neurolysis can be extremely rewarding. Kate, should I go into my geek out straight away?
Go for it.
Right. So completely off the charts, my favorite nerve, long thoracic nerve. Serratus anterior, 3 parts, upper, middle, lower. C5, 5, 6, upper, middle, but C7 is the most important for stabilization. The concept of entrapment of long thoracic nerve is not new. It has been described by many people, but there are multiple points from the neck to the chest wall. If you look at anatomy book, you will be misled. Long thoracic nerve doesn't lie this way. In fact, it is parallel to the upper trunk, as you can see here, C5, 6, 7. 5, 6 tend to pass through the body of the scalenus medius, while 7 pass in front of the scalenus medius. This is after the decompression, and you can see this actually received a contribution from C4. Another example, upper trunk, long thoracic nerve. And if you go down to the chest wall, look out for the crossword lesion, which is the tributary from the thoracodorsal nerve. That's my geek out. Thank you.
Brilliant. Thank you very much, CY. That was fantastic. Yeah, some really interesting stuff coming out of that. I was thinking about my pasta classification. As long as it doesn't look like rigatoni, that would be really bad.
I think the shift should be a penne, and then you have to have a number of linguine, and then depending on how many or how much time it has been compressed, it may turn into certain type of pasta, but we have to incorporate the consistency as well.
That is true. That is true. So what the hydrodissection, that's really interesting. I was going to ask either Tom or Chris if they use hydrodissection in their investigation findings. Tom, do you want to go first?
No, this is the first I've heard of it. I'm interested. Let's see some data.
Chris, is this something that you've come across?
It's something that I've seen physiatrists or physical medicine doctors use. Anybody who is essentially an ultrasonographer and a proceduralist has tried this. I actually, for the intent that CY is using it for, I actually like a diagnostic block under ultrasound guidance, as opposed to the hydrodissection. I think the diagnostic block in the patient with pain is incredibly helpful to hone in on a diagnosis, confirm the diagnosis that you have gathered from your physical assessment. And also, I think it's important to help give patients confidence that you will be helping them if you intervene on their nerve.
Right. So CY, what was the, why did you decide to start using it? Where did the sort of inspiration come?
Well, I work with very many excellent radiologists, and we have rooms next to each other. And for complex cases, we always use ultrasound as an adjunct to my clinical assessment. And I use a lot of nerve blocks. Sometimes it works, sometimes it doesn't. And hydrodissection doesn't work all the time either. It's, if you like, it's just another extension. And it's a lot of a confidence building, rapport building with the patient, because I will be in the room as well. And then we can show to the patient, wow, you see, this is like, well, reaching that plane, injecting. I think the effect is equivalent to a properly performed nerve block. It hasn't given any longer lasting effect than what I would have obtained from a nerve block.
No, it's really interesting. Been looking forward to seeing a bit more of that. I think one of the really great points was, you know, if a patient wakes up after an operation and it's hurting, you've got to do something about it. I think that is absolutely a number one take-home point. I remember a case I had of a guy who'd had a non-union of a clavicle at 5 weeks, who had it operated on, and woke up in excruciating pain. And this was put down to some problem with his, he'd had a supraclavicular block for his anaesthesia. And it was sat on for a couple of weeks. Ended up needing to have a well, we did a full supra and infraclavicular release with a great result. But the point is, don't sit on these. They need to be addressed immediately. So I thought that was a great point. Final question, and again, this whole CRPS thing, probably going to say something really controversial. Is CRPS really a thing? What does the panel think?
Well, let me start then. I've been hand surgeon for 7 and a bit years, and I have a hand clinic, so I deal with a lot of neuromas. I have probably about a handful of patients that I would truly call CRPS, but I manage them with the pain doctors, with the physiotherapists. Now, there are a lot of patients who have elements of CRPS. Whether you call it CRPS or not, it doesn't really matter. If you recognize it, you're concerned, it doesn't preclude you from referring the patient to pain clinic either. But what you must not do is suddenly shut you shut off, you stop thinking about the patient. And I think that's the message that I want to get across.
Tom, what about you?
Yes, see, there is clearly a interplay of multiple factors which creates a neuropathic pain which is not understandable easily by our normal mechanisms. And I think there is a great role for this multidisciplinary assessment, treatment, multimodality treatment, but you have to have a surgeon as part of that MDT team. We get left out of so many MDT teams, but there are certain things that surgery can improve on. The most important thing within that Budapest classification, which is I've got a lot of issues with them, we can do a whole talk on CRPS, but it's very clear it is a diagnosis of exclusion. So if you've got another diagnosis that explains those symptoms, it is not CRPS. So Rolf hated it as a diagnosis because it banished people to vitamin C and mirror boxes when they could have had the potential for cure. So it isn't a homogeneous group, it's a massively heterogeneous group. And some of those that are labeled within that heterogeneous group could actually have a potential for treating the cause, not just treating the symptoms, and therefore being free of pain. I could geek out on that as well, but not now.
What about you, Chris?
Yeah, I think I kind of fall somewhere in between what CY and Tom had described. And I really do think it is a true diagnosis. I agree it is more of a diagnosis of exclusion. And, you know, I think that a lot of what we end up seeing as hand and peripheral nerve surgeons is the type 2 that is associated with immediate, you know, a particular peripheral nerve. And that's where I think that we have the ability to intervene. I think that you're seeing a lot, at least in the US, we're seeing a lot of a big push towards surgery for pain. Some of that is fueled by industry in terms of innovation, in terms of the potential surgical techniques, which is bringing the awareness to the fact that we can potentially help patients I worry that even in my personal practice, perhaps the pendulum is swinging too far, and maybe we are operating on too many patients for presumed CRPS type 2 when there is another diagnosis at play. And that's where I think you're going to see a big shift in the next 5 years, is that I think we're going to go too far in terms of operating.
Perhaps I can say a few more words about CRPS type 2. I see that in our chat room, there is also a question about CRPS type 2. Well, this is my personal view. Obviously, just for those who are not familiar, there's type 1 where there's no nerve injury, type 2 where there is actually a no nerve injury. But I think it's awfully unfair. Let's say somebody has a dequervant surgery and the superficial radial nerve has been transected, and the person has pain, distribute allodynia, all confined to the dermatome of the superficial radial nerve, even though the symptoms will fulfill all the classification of the 1, 2, 3 in Budapest criteria. I would not call that CRPS type 2. I would simply call that as superficial radial nerve neuroma or pain. Now, if this patient develop pain out with the dermatome in the ulnar nerve, in median nerve, and perhaps even pain radiating up to the forearm, to the shoulder, which cannot be explained by this superficial radial nerve alone, then in my books, I would call it CRPS type 2, but I recognize that the superficial radial nerve injury was the driver.
I've actually got, so Carlos has just sent us a message. Nice to see you, Carlos. He's actually asked if how we can tell the difference between either neuropathic or nociceptive pain. So I'm going to put that question back to CY.
I think history can give you some idea, but the patient hasn't read our textbook. So the way I look at it is I work very closely with pain specialists. And I work very close with neurosurgery as well. So if the patient has pain, we look for causes and then just deal with all potential causes. If there's a mechanical issue, we deal with it. If there is nerve-driven problem, we deal with it. Just if you allow me, I have great neurosurgical friends who now put implants, neuromodulator peripherally as well as centrally. So I have lots of peripheral strategies as well as central strategy as part of my armamentarium to deal with the whole spectrum of pain, I hope.
Great. I think we've got to 9:30 now, so I think probably we're coming to the point we probably ought to draw this to a close. So what I'm going to do is share my screen and give you what I think were probably our take-home points. So would help if I started at the beginning. So these are your take-home messages from the nerve nerds. So thanks to Tom. Key points from his talk I felt was it was all about MTSP and you need to assess them all. Probably the whole classification system isn't really necessary anymore, but you need to be able to tell the difference between non-degenerative and degenerative injuries and whether those have got either a favourable or a non-favourable prognosis. But really importantly, you've got to make a diagnosis and you've got various modalities that you can be using to make that diagnosis, but certainly clinical history and examination, key. And you need to have your MDT input. Chris emphasised the point that watch and wait is an active process. Active, it's got a dynamic process to it. You need to go find the nerve, not the nerve was never seen. You need to be able to assess your neuroma in continuity. Hope is definitely not a surgical strategy. And then we talked about the tension test for those gaps. And quite broadly speaking, you're either trying to narrow it, bridge it, or bypass the gap, depending on your strategy. CY told us very clearly, if it hurts, release it, really important. And again, you need to be assessing your other nerve modalities. Consider all of your MSK components. So it's not just about a nerve, there are your surrounding biomechanics. And think about in your delayed procedures, there's going to be scarring and callus, and you might have a tethered nerve. And guess what? You need to make a diagnosis. So these are just my thoughts as well. You've got to own that patient and you've got to own the injury. These patients start their journey in our fracture clinics and they're often left festering there for months on end. Don't let that happen. Make sure that you, like I said, own it and do the appropriate things. Pre-op examination, my big bugbear. Every time I hear they're neurovascular intact, I don't believe it. The neural examination should be specific to what you're examining for, and it needs to be documented clearly. get help early. You've got plenty of people around you. And therapy. Don't leave them in a position where they're going to end up with contractures, because then it's irrelevant what happens down the line. And finally, you need to make a, oh, hang on, we've talked about that. Thank you very much.
Kate, thank you for hosting. That was fantastic.
You guys did a great job. So I think that probably brings us to a close. I think Ramon wanted me to finish this up. So I'm probably just going to end the session. We've had a whole bunch of questions and answers, which I know we've been trying to answer en route, and the boys have been doing a great job as well of putting those answers online. Mike will at some point, I think, download all of those, put them on the website so you'll be able to access them. And you can obviously access this at a later date via the OrthoHub link. So many thanks, and we shall now end the session.